Good morning to all. Today I am going to discuss a very important topic on cardiac output and the factors affecting cardiac output. As name you could see cardiac. Cardiac means heart output. So how much blood is coming out of the heart? To be proper definition, first I will draw the diagram, a rough diagram. Right atrium, left atrium, right ventricle. Left ventricle is a little bit bigger, and from the left ventricle you are having the aorta, and from right ventricle pulmonary artery. So the definition of cardiac output is the amount of blood ejected from the ventricles per minute. Very important. I again repeat, cardiac output is the amount of blood ejected from the ventricles per minute. So it could be either right ventricle or left ventricle. So the left ventricle pumps the blood and then send the bloods into the aorta for the circulation. So this amount of blood pumped from the ventricles for 1 minute, that is called as cardiac output from the heart. In fact, the amount of blood pumped from the right ventricle is also the cardiac output, but the right ventricle will pump the blood into the pulmonary artery for 1 beat. So for 1 beat, how much blood is the ventricle pumping? That is called stroke, 1 stroke otherwise. So stroke volume. So for example, when we will take example as ventricle. For ventricle, the definition is the amount of blood ejected from the ventricles per minute, any one ventricle. So I will here take example left ventricle. So when the left ventricle pumps 1 beat, that amount of blood comes is called a stroke volume, which is approximately 70 to 272 ml per beat or per stroke. That's why it is called a stroke volume. So for 1 beat, it is called a stroke volume, but our cardiac output definition is per minute. So you have to know for 1 minute how much the heart beats. Otherwise simply it is heart rate, which is 72 per minute. So for 1 minute your heart or ventricle is beating 72 times. We have already calculated for 1 beat it is 72 ml. Then for 72 beats it is 72 into 72 or 70 into 72, which is approximately 5 liters per minute. Factors affecting cardiac output is stroke volume into heart rate. Factors. Now I will concentrate on stroke volume. Stroke volume we know, see here, the amount of blood ejected from left ventricle into the aorta. So this is the stroke volume. Now next, stroke volume depends on 3 things: preload. So listen here, preload is nothing but preload. So before the heart is filled up, whatever is going to come to the heart. So when the more blood is coming into the ventricles, which is preload, before filling, when more blood is going to enter into the ventricles, there is going to be more output in the form of stroke volume, which is determining the cardiac output. And another thing is contractility or contraction. So when the heart contracts well, more blood is going to come out of the heart, here again stroke volume is going to be more. Then there is another thing called afterload. So afterload is after the load. So already the blood is filled up, and which is preload, and the ventricle started contracting. The ventricle is contracting, but after the contraction something is preventing from the blood going. So that I will discuss. That is called as afterload. So as of now, remember, there are 3 factors: preload, contraction of the heart, and afterload, which determines the stroke volume. So now I will be explaining about the preload. So preload is whatever is going to come into the heart, that is otherwise end diastolic volume. End diastolic volume. So end diastolic volume is the one which determines the preload. So what do you mean by end diastolic volume? Diastole means ventricle relaxation. So when the ventricle is relaxing fully, how much blood is present in it? For example, imagine normal usually end diastolic volume is 130 ml. So when your end diastolic volume is 130 ml inside this, so out of that 130 ml only something is going out of stroke volume. Otherwise, end diastolic volume is directly proportional to stroke volume. Now next question, why end diastolic volume increases the stroke volume? Otherwise, end diastolic volume, if it increases, why stroke volume increases? So very important, it is called as Frank-Starling's law. Frank-Starling law. I hope you know that. So what Frank-Starling's law states that the force of contraction is directly proportional to force of contraction is directly proportional to initial length of muscle fiber. Very important. So here it is cardiac muscle fiber. So end diastolic volume is increased. So for example 130 ml. So whatever is coming, usually it comes through inferior vena cava, superior vena cava. So for example, if the end diastolic volume is 150 ml, so what happens? It stretches. This end diastolic volume stretches the ventricular muscle fiber. And according to Frank-Starling's law, the stretch of the muscle increases contraction. So whenever end diastolic volume is more, as the volume is increasing, it stretches the ventricles. Or otherwise, we have to apply this Frank-Starling's law. So once the muscle is stretched, the initial length of the muscle fiber is varying. So because of the stretch of the muscle fiber, it causes contraction. So once the contraction is there, it causes increased stroke volume. So now I told how increased end diastolic volume will cause increased stroke volume. Now next question. Now again this end diastolic volume depends on many things. This end diastolic volume depends on venous return. So what is venous return? As I am mentioning in this diagram, so from the lower part of the body, the blood comes to the heart through the inferior vena cava. From the upper part of the body, the blood comes to the heart through superior vena cava. So this is venous return. So when venous return is increased, end diastolic volume will be increased. When end diastolic volume is increased, preload is increased. When preload is increased, stroke volume is increased. So venous return is one of the important factors which affects the stroke volume and obviously cardiac output. This venous return which is coming into the heart is dependent on muscle pump, respiratory pump, venomotor tone or venoconstriction. I will explain it. So muscle pump, imagine your calf muscles, you are squeezing your calf muscles. So what happens? The blood will be coming upwards towards the heart. So the venous return increases. That is called the muscle pump. So whenever the muscle pump is activated, it increases the venous return. So when the venous return is more, the filling of the ventricles will be more, which is end diastolic volume. When end diastolic volume is more, preload is more. Preload is more, stroke volume is more. Stroke volume is more, cardiac output is more. Simple. Now coming to respiratory pump. So in respiratory pump, what happens? For example, during inspiration, I will make it simple. So during inspiration, what happens? There will be inflation of the lungs, so it compresses the diaphragm. So there will be positive pressure in diaphragm. Our diaphragm muscles is contracted and intrathoracic pressure will become more negative. Intrathoracic pressure becomes negative. So the negative intrathoracic pressure and increase the pressure on the diaphragm. So what happens during inspiration? This happens and this increases venous return. So I have discussed muscle pump, I have discussed respiratory pump which increases venous return. Now coming to venomotor tone, as the name suggests, venoconstriction. So whenever the veins constrict, more blood will be coming into the heart. So venous return is increased. So all these increases the venous return. One more important thing which I want to discuss is filling time. Filling time is very short. That is, the ventricles is about to take the blood. Before that itself, ventricle, this happens when your heart rate is greater than 180. When your heart rate is greater than 180, filling time will be very short. That means the blood is not, the ventricles is not properly filled with blood, or end diastolic volume will be less. That is, when your heart rate is greater than 180, I will separately explain it when I am explaining about heart rate. So just note down, filling time is also one of the factors. That is, you need some time for the ventricles to fill. That also determines your venous return. So I have discussed about preload. Now I will be telling about contraction, which is another. So I will keep this as factor 1, factor 2, factor 3. All these are determining stroke volume, and factor 4, which is heart rate. Now I will be explaining about the factor 2, contraction. So you all know, when the ventricles contract, the stroke volume is going to be more. So what are the things that causes contraction? Very, very important, sympathetic. So sympathetic increases contraction, norepinephrine, adrenaline, noradrenaline. So all increases the contraction of the ventricles, which increases stroke volume. Opposite, parasympathetic. Parasympathetic will decrease the contraction. Example, acetylcholine. So acetylcholine will decrease the contraction. So some drugs are also there. Atropine. Atropine will increase the contraction of the ventricles. So we call this as inotropic. Positive inotropic, this as negative inotropic. So positive inotropic means which causes contraction, negative inotropic means which causes less contraction or relaxation. So acetylcholine is one of the drugs which is negatively inotropic. So the acetylcholine will decrease the stroke volume. And many drugs are there like digitalis, which causes increased contraction. So we have discussed preload, we have discussed contraction. Now we will go to afterload. So just listen. So whatever is coming to the heart is preload, which is depending on end diastolic volume. So the preload, when it is increased, when input is increased, output is going to be increased, which is stroke volume. So contraction, when the ventricles is contracting well, more blood is coming out of the heart, which is stroke volume. When the ventricles are not contracting properly, less blood will come out. Now the third factor is afterload. Afterload is, so venous return has come, ventricles started contracting. Afterload is, after the ventricles contract, what happens? So at this level, this is afterload. So afterload means, for example, imagine atherosclerosis. So here in the blood vessel aorta, there are some cholesterol deposits or narrowing of the blood vessels. So there atherosclerosis occurs. So atherosclerosis. So what happens to this lumen? You can just see it is reduced. So what will happen to the cardiac output or stroke volume? The stroke volume will be less. That is called a resistance. So whenever afterload is going to be more, the stroke volume is decreased. So the factors that determine afterload are, one is atherosclerosis, another is vasoconstriction, Yeah, as I was telling, when the vessels constrict, the output is going to be less. One of the condition is atherosclerosis. Then you have increased blood pressure. So whenever BP is more, blood pressure is more, the afterload is going to be more, and that also will decrease the stroke volume. So this comes under afterload, which is also one of the factors affecting cardiac output. And same way, any valvular heart disease. For example, if there is aortic stenosis, so what happens? Preload is normal, ventricle contraction is normal, but the afterload is more. That is, the blood is not be able to be pumped because there is aortic stenosis. So all these are factors which influence the afterload. Now let me go for heart rate. Very important next. So I will tell about the heart rate. Again, it is also under autonomic regulation. So sympathetic increases the heart rate. Same adrenaline, noradrenaline increases heart rate. Epinephrine, norepinephrine increases heart rate. Parasympathetic decreases heart rate. Acetylcholine decreases heart rate, and even some electrolytes for that matter. When there is increased calcium, heart rate is increased. Decreased calcium, heart rate is decreased. Decreased potassium increases heart rate. So here we call this heart rate the factors chronotropic. So whichever drugs that increase heart rate, we call it as positive chronotropic. Whichever drugs decreases heart rate, we call it as negative chronotropic. So very important. Yeah, here in the contraction many drugs are there, digoxin, dobutamine. So all those drugs which causes contraction. Now very important term which I thought I can mention is heterometric homometric regulation. So many might not be able to understand this easily. Homo means same, hetero means different. So I will just tell, already we discussed. For example, imagine this preload. This preload is nothing but depending on initial length of the muscle fiber. So only when the length varies, there is going to be increased stroke volume. So you now can answer yourself whether this preload is heterometric or homometric. Homo means same length, hetero means different length. So here what happens, when the end diastolic volume is increased, or when the blood coming to the ventricles during relaxation is more, there is a stretch of the muscle fiber. Stretch of the muscle fiber means length varies. So this preload is heterometric regulation. Now coming to contraction of the heart. So this contraction of the heart is independent of initial length of the fiber. So this contraction is homometric. So I again repeat, this preload is an example of heterometric regulation and it follows Frank-Starling's law. Whereas the contraction of the ventricles, which is not depending on whatever comes, this contraction depends on ANS, autonomic, whereas this preload is not dependent on autonomic nervous system. This contraction of the heart depends on autonomic nervous system. Like sympathetic increases the contraction of the heart, parasympathetic decreases the contraction. So this is homometric regulation, this is heterometric regulation. So that I wanted to mention. So I want to summarize overall. So today I discussed on cardiac output. The definition of cardiac output is the amount of blood ejected from the ventricles for 1 minute. So I already mentioned for 1 beat it is 70 ml per beat, and your heart rate is 72 beats per minute. So 70 into 72 approximately it is 5 liters. And the factors affecting cardiac output are stroke volume, and heart rate. As the formula is cardiac output is equal to stroke volume into heart rate. So totally 4 factors. For stroke volume you have preload, contraction, afterload, and 4th factor is heart rate. For preload, whatever is going to come into the ventricles is dependent on end diastolic volume. So see here, end diastolic volume is 130 ml, and the factors helping for the end diastolic volume is venous return. So whenever venous return is more, end diastolic volume will be more. So what are the factors that influence venous return? I mentioned muscle pump, respiratory pump, venomotor tone, and filling time. Yeah, in heart rate, for imagine if your heart rate is greater than 180. So though the heart sympathetic increases the heart rate, which increases cardiac output, but it is up to a certain level. What happens when your heart rate is greater than 180? Your heart contracts. Your heart beats for 180 times per minute. Then imagine. So when your heart relaxes, the end diastolic volume will come. Or otherwise, when your heart relaxes, the venous return is sending the blood. But before the blood fills, the heart starts contracting. Then what happens? Your stroke volume will be becoming less because the venous return is less. So the end diastolic volume is less because even before the blood fills the ventricles, it starts contracting. This is in the case of when the heart rate is there. That's what I mentioned in the preload. Filling time is also one of the important factor. But less than 180, as the formula suggests, whenever heart rate is more, stroke volume will be more and cardiac output will be more. That you have to remember. Contraction is homometric regulation. It is independent of the initial length of the muscle fiber. Preload is heterometric regulation. It depends on the initial length of the muscle fiber. That is, when end diastolic volume is increased, length of the muscle fiber increases and contraction is increased. Frank-Starling's law. Then afterload is, once the ventricles contracts, what happens after the contraction of the ventricle? Some factors are there. For example, as I mentioned, if there is atherosclerosis, some constriction, so the afterload will be more and your cardiac output is decreased. Again, vasoconstriction, your cardiac output is decreased. When your blood pressure is more, cardiac output is decreased because the pressure is high. Your ventricle has to contract against that increased pressure. Valvular disease like aortic stenosis. So what happens? There is an obstruction in the outflow. Again, the cardiac output decreases. So today we discussed about the factors affecting cardiac output. Thank you.